Oh, yeah, we do.
Good morning and welcome. I will call to order the Board of Health meeting for March 26, 2025. We have two board members not present today, Alicia Tobin and
Catherine Saluskin and Lupita Carrier are not yet here yet.
okay, but do we have a form? We do? Okay, great, thank you. All right, next on the agenda is introduction of guests and staff. Do we have anyone?
No staff or
Okay, thank you. We'll move right along here. Third on the agenda is review of submitted public written comments.
no written comments.
Wow, no fans today.
No.
Thank you. We'll move on.
God, this has gotten boring.
That's not a bad thing.
All right. Oh, Lupe, good morning. Thank you for joining us. Yeah. Fourth on the agenda is the consent agenda. All items listed with an asterisk are considered routine by the board and will be enacted by one motion. There will be no separate discussion of these items unless a board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence on the agenda. Would you read the consent agenda?
February 26, 2025, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in February 2025 in the amount of $1,085,028.15.
Thank you. Anyone want to remove any one of those for discussion separately? If not, I would entertain a motion to accept the consent agenda.
Motion. Second.
Thank you. So we have a motion and a second to approve the consent agenda as read. All those in favor, please say aye.
Aye.
Aye. Any opposed? Thank you. Motion passes. Fifth on the agenda is the Yakima Health District Spotlight for flu and RSV status update by Lillian Bravo, our Director of Public Health Partnerships.
Good morning, everyone. So today our spotlight will be on something that's been taking place for many years, but aptly as we call the presentation, we're going to put a spotlight on how exactly something like this happens. So I forgot slides now. So we're going to start with what the purpose of surveillance is. Surveillance, in layman's term, is really just tracking information in a systematic way over time. And as I mentioned, today we'll be talking specifically around flu and RSV information. The purpose of tracking this information is to help anticipate hospital capacity and the resource needs. It's also to help make sure that we can identify when there's spikes in disease transmission, again, what we're talking about today being flu and RSV. Helping to predict, again, those hospital capacity and resource needs. And ultimately, depending on what the information is showing us, we may also use that to help inform the public on what is currently happening. That way the public can make their own decisions about what type of precautionary measures they need to take, depending on what the risk they see for themselves is at that point in time. I'll start with the national surveillance. Nationally, here in the United States, it's the Centers for Disease Control that is responsible for tracking the information across the country. And I'm going to start with how they do that so you can see why we implement it the way we do locally. So at the CDC level, they do track the information year round, but technically at the national level, flu season is set to begin on week 40, which is also the first week of October. Typically, the season will run through the end of March, but again, that depends on the flu activity on that particular year. And the reporting that the CDC utilizes focuses on the previous week. So every facility is set to report information on every Tuesday of the following week for the preceding week. So as I mentioned, that because the CDC follows this type of tracking system, that's why we at the Yakima Health District do the same to make sure that the information that we collect locally is consistent with what is being reported nationally, and you can do apples to apples. So here in Washington State, flu and RSV are not considered reportable conditions. And so the information here at the Yakima Health District from the hospitals is completely voluntary, which shows a great partnership from these hospitals to provide this information to us so that we can then compile it and report it back to them for their use. The information is being collected currently from the three major hospitals, being Estria Toppenish, Estria Sunnyside, and MultiCare Memorial. Again, they also report this information to us every Tuesday for the preceding week. We are then able to put this information in a report, and the hospitals do end up using this information for their own policies and procedures. For example, right now, Memorial is currently using our information to show that flu activity is high in Yakima, and because of that, they're asking that guests use masks. When that changes, when it's no longer high, I'm assuming they'll change those recommendations.
Lillian, if you go to like an urgent care, none of that stuff is shared with us.
Not at this point in time.
Unless the labs are done at one of the hospitals.
Gotcha.
Thank you, Dr. Ward. Previously, you can see what our old report was versus what our new dashboard is. So getting into why, making some of these changes, the changes that we made were primarily for accessibility and for efficiencies, but also one of the pieces that happened during the pandemic, as we all know, most of the public was more interested in looking at data themselves and being able to access the data in a more timely manner. So having that increased interest from the public, we wanted to have an increase in our prioritization of data visualization, which basically means presenting data in a way that's more accessible and it's more easily understandable by the general public. What we ended up using with this new dashboard is utilizing a software called Microsoft BI, which stands for Microsoft Power Business Intelligence. It's part of, again, the Microsoft suite. So we actually already had access to it. We were just able to learn how to utilize it and apply it to this. For those of you that are familiar with the county, actually the same system, Power BI, is utilized in the courts and the judicial system to outlay information data as well. So it's kind of interesting, but that's an aside.
Thank
She
you.
loves-
She loves this.
That was really cool. And a special thank you to David Welton at the county for helping us get this started as well. And so this dashboard is actually available straight on our website. When you go on the main page, you click on flu and RSV stats and you'll be able to click through it. What it does is summarize the information in a way that's more digestible. And on the back end, it's much, much more efficient. We are, with the click of a button, we can update the information where previously we had to spend hours just updating every chart one by one. So it was twofold of a benefit, making it more accessible for providers and the community, but also for our staff to spend less time having to do some of those pieces and get advanced with technology. And as I mentioned, depending on the information on any given year, if there is increase in flu activity or when there is a flu death, we do make sure that the public knows. And again, for the reason of people being aware of what the current disease activity is in the community. And if they consider themselves to be high risk, they can take those extra precautions if they choose to do so with the information on hand. So again, what that public notification includes media releases, radio interviews, social media posts, just to let everyone know what's currently happening in the community.
Quick question, Lillian, when we look at flu deaths, what's the age range that you typically see that those deaths occur?
65 and older, and usually if they're younger, it's usually accompanied by underlying health conditions.
And so just a quick update from the information available as of last week. There were as of last week, 12 deaths in Yakima County. I don't believe any of those were pediatric deaths. And as it says, and this positivity rate was at 17.5%, which is lower. It looked like at the end of February that the activity peaked at around 25%, and it's been going down, but we'll see what the next couple of weeks look like. It is late in the year for the flu season to be happening, so technically people are still recommending if you haven't gotten your flu shot, you still have a chance and it still might be valuable given the increase in activity overall.
Interrupt 1 second.
Absolutely.
So 17.5% is of all the influenza tests sent to the laboratories, 17.5% of them are positive.
Thank you, Dr. Bard. And actually, given the dashboard, I mean, if anyone's interested, I'm happy to walk you through it, but you can actually see all the breakdown, the different types of influenza, whether it's A or B. There's also sorts of information for anyone that's interested in looking at that as well. Oh, wrong way. And and again, tying it back to our strategic goals, deliver mandated services, of course, making sure that we're tracking communicable disease that's related, developing the network of partners, working with the hospitals, but also using the community as our partner to make sure that they're aware of what's going on. And increasing the effectiveness and efficiency is, again, helping other organizations make their policies and procedures recommendations based on the data available, but also on our end for our team to be able to spend less time doing something that can get automated and look a little nicer. Any questions?
How far back does our data go on the influenza death? How long have we been collecting the data for? With for Dr. Parkman,
A long time.
pre-1980s, pre.
Influenza deaths are notifiable, so those are required to be reported by agencies. So those have been investigated for years and years. I mean, I'm sure all the historical data is somewhere in an archive with the state. But as far as on Power BI, I mean, I know, looking back at our records on the website, go back probably at least 15, maybe 20 years.
Well, I found record keeping books from the 20s, 30s, 40s, where it was every death was in the same sense that when people lived on a farm, the Bible had the names and deaths of everyone literally did have that by hand. That's
Wow.
what people would do.
Yeah.
So it's been tracked for a long time.
In legible cursive too.
I could read it.
Keeps records for every communicable disease back to, I want to say, the 20s, and you can get that data.
It would just be interesting, to look at.
I think you should.
Yeah, I'm sure during those flu pandemics that it was quite high.
Right.
And in fairness to Mayor Byers, that the entire cursive diction, everything in there was perfect. So it
was.
wasn't put in by a doctor. I really,
I'd say that.
but I do want to share with you, it was the same handwriting, which meant that somebody had a responsibility to do this. So in a sense, pre-computer, there was a person who was responsible for that data collection and that data acknowledgement, which is really interesting because that's what we're talking about, keeping track of things.
Nice.
I actually look at doctor's handwriting as a continuation of Alfred Smith's papers, the original descriptions from the Egyptians on healthcare, medicine in general. We kept up our tradition.
Modern hieroglyphics.
Hieroglyphics are really sloppy.
We're gonna take a writing sample, Dr. Park. All right,
Just a note, I would say, I like your dashboard update. That does make it more easily accessible and digestible by the average reader. Good step forward.
Well, and if I may, I would ask to also share, it's a team effort. I don't know if you want to mention all the people involved, but it went from essentially an Excel spreadsheet to something quite good.
Yes, I mean, and that's the neat part to be able to see it here at the health district, everything from the actual data entry, from collecting the information from the hospitals. I mean, that has to get into the spreadsheet. It has to be analyzed by our epidemiologist, and then on the back end, actually putting to the dashboard a whole nother individual who's responsible for that. So it's lots of different skill sets that go into creating something like this. And I agree, it is much more digestible. And honestly, we're being held accountable by the public because anytime, at least during the pandemic, when we didn't update our reports, people would call, they wanted to see those numbers. So we want to make sure that we're able to respond to what people want to see and provide that.
no, thank you. Any more questions or comments or jokes? Thank you.
Add that on the dashboard now, we worked with our hospitals, our epidemiologists, had a great idea to start including the date of births for these individuals, so we can see who's actually being, at least having to go to the hospital to be tested, because we're not getting them from outpatient clinics, these are the hospitals, so people are showing up in emergency rooms and who are being tested, and be able to tell what age brackets are being most affected. It's really important when you're looking at, because we know that young children and immunocompromised individuals and older adults are most affected, so it helps us gauge that. So that information is also on the dashboard that we packet.
Thank you. Anything else? If not, we'll move on. Great report. Thank you, Lillian. Into our agency reports, we'll start with our executive director.
Thank you, Myers. Good morning to the board, everybody watching. Thank you for being here today. First, I'm hoping to just follow up on what Lillian was discussing with our spotlight, which is that we have adopted years ago a team approach so that when we have things we want to address, we address them as teams as opposed to just departments. And so that's worked out quite well for us. We have people working with different skill sets, but they come together for a project, which means that we don't miss things. Obviously, if we're going to automate something, we want to make sure that it's correct. We want to make sure that it meets the standard. And to your point, we want it to be easily understood by the public. But sometimes what looks easy is actually pretty complicated on the back end. So that's what we're trying to do, is simplify And also frankly, be smart with our time and our efforts, because the county already had a great system. We had to understand the system. We understand the parameters of the system. And again, we don't take it lightly. We can't just say, well, because it's a computer system, it's going to work. Well, once it gets vetted, once it's cleared up, now we benefit from that because it is simplified. And there are many people taking a look at it. That's the other thing, is we want many eyes on these things to make sure it works. But it really is exciting for me when we have internal competency that allows us to address an issue and not just say, well, this is how it comes from the state, and this is antiquated, and I wish it were different. And to make those inroads and do it on behalf of the community just brings me a great deal of satisfaction, because that's what we're here for. And so it's not just to work hard, it's to work well. And if we can educate the public and simplify the process and make something that frankly becomes a standard for other jurisdictions, it's really exciting. So thank you for your understanding that this investment is not just about meeting the current standard, it's excelling and doing something better. But I would say that I can have an idea, but the team are the ones that put it together. And this team approach is working really well for us. So thank you for understanding about cross-training and why we have the staff.
May I add something to that, Andre?
Is
Just that the state gathers their data from laboratories that do report it in counties that like hospitals or laboratories that report for specific areas. But if we didn't have this data collection with our local hospitals, we would have no idea the actual numbers happening within our local community. So it's a really great partnership with our hospitals that they do this, even though it's not required. It's a commitment to our community on our behalf as well as theirs. So
yeah, it is definitely a community approach, but it's great to have a working relationship with the county. It saved us some immeasurable time. We just don't have to worry about trying to figure it out on our own. And I think sometimes in medicine, it's easy to overcomplicate things and talk about why it's so complicated. And we try to take the approach, how do we simplify this and get to the very bare bones of what's necessary and then build it? I mean, that's what you're saying. So it's the same model that we try to approach everything with. So really, really grateful for your support. I wanted to transition, please, into just a recognition, and this will be something that we'll talk about probably at each board meeting for a while, which is the complexity that we're dealing with state and federally, and the concerns financially with state and federal funding. The state is in the middle of their process of coming up with a state budget, which I know you're all well aware of. It's something we'll hear about probably in early April. And the question is, to what degree are there going to be cuts? So there have been discussions about potential cuts for current funding, but we already have what are referred to as consolidated contracts. I will defer to Chase in his report if you have questions about the specifics, but the bottom line is that we're not anticipating any current funding reductions, but I do anticipate funding reductions in the near future. But the question is, to what degree? We have foundational public health services funding, which comes directly from the state legislature. We have funding from the State Department of Health, and we certainly have federal pass-through dollars. The federal pass-through dollars, I don't anticipate us knowing anything about until summertime. And of course, the new federal funding cycle begins October 1. So we may not hear for a while. But history has been that if there was a funding revision at the federal level, the state could sometimes come up with those funds. I don't anticipate that happening. So the real question is, where is the state going to make put their efforts? What are the things they think are fundamental? And I can't speak to that yet. And so I hesitate to continue to say, I don't have an answer, but I think the only answer is, I don't know. So I want to be straight with you about that. Having said that, our current budget is strong, and we feel very confident in it. So I wanted to transition to something else, but I certainly wanted to hear from the board if you have questions on funding or anything we know in terms of the current budget. Okay. Well, we have seen that the governor is staying true to his plan, which is to reduce the budget at the state level, and notices are going out currently to state employees, certainly at the State Department of Health. We have confirmation of that. We're talking about many people being told that they're going to be laid off. I believe is that July 1? I think that's what I heard. June 30. That would make sense. So, it's, not an easy time there. I think their staff grew, very, very large and there are programs I think that the governor does not want to continue to fund. And there are subsequent reductions in staffing for those departments. But that's happening at the, certainly at the staffing level now. But it's not just, what we would refer to as frontline staff, it's staff at all levels of the agency. They're being quite tight-lipped about it, I think out of respect for the fact that people's employment status is changing, but it's happening throughout the agency. We're hearing about this very slowly. I think that this has been a tremendous about face from the way things have been. So we're just waiting to be informed. But that changes whom we speak with and the projects and some of the complexities. So I will share with you that as an example, when we talked about the transition away from supporting the Spokane region for the breast cervical health program, it adds complexity if there are people who were in those positions that are no longer in those positions. So that will take more time for us to figure out. There's also been really restrictions on travel for state employees. So we're seeing less of state employees. So we may have to go to them to get answers sometimes, but that's our plan currently. So I just wanted to give you an update. The only other thing that I really wanted to touch on in my report was the building. There are updates that Ryan will have, and if there's specific questions about the building in terms of finances, please feel free to speak to Chase about it. I'm going to ask if we can be cautious about specific amounts of money because we're still in a bid process. So we have put out for bid, and the bid closes it then on April 4th.
Yeah, you're taking my report, but go ahead.
Well, I'll forget by then, so you
All
can
right.
tell me again. But the bottom line is that I do want to be cautious in going into specifics. But the board did discuss the cost of the building renovation at the last board meeting, and I want to be respectful about that. We looked at our finances again and again. We have a strong budget currently. We have an enhanced budget that the board approved, which included potential investments like investing in what we would call a seed investment in the Emergency Operations Center. That again has been put on hold because federal funding was not available, but we had considered between $250,000 and $500,000 investment as a board. So we have $500,000 that's in our enhanced budget that would have gone to the EOT that probably will not go towards a project in this fiscal cycle. So we have assets there. We have foundation assets that were invested through the Group Health Foundation, now called the MSI Foundation. We have a strong budget currently. So the cost of the renovation is well within our means currently. I wanted to share with you, I have no reservations about that, and neither do you.
Agree. Yes.
And Ryan's comfortable too. So there's that. The other is, though, we have been very thoughtful about the process. The board had entertained a much larger investment if we had bought a building. We're looking at a much smaller investment. We also, when we were offered the opportunity to work with the architect, the cost was larger. We've reduced those costs. So we still have a fine footprint, but it's, I'd say, far more thoughtful financially. It's tighter. And we've also looked at our internal processes here, and we've found some significant cost savings. I can give you a few examples. If we had our attorney present, it would cost far, far more. So if you add that times 11, that's a significant amount of money. And so we've chatted with Mayor Byers about that. And so that's one way that we can reduce costs. If we need the benefit of an attorney, we're happy to do so, but having someone come from the Tri-Cities to sit here and not utilize their services is expensive. So there's one where we can have belt tightening. I have not gone to a lot of conferences over the last few years. We've had issues like fires and landfills and, public safety power shutoffs and all sorts of things that got in the way of that. We talked about that, but I'm not comfortable going to conferences where the cost of going to the conference is $800, $1,000 before you've even paid for airfare or hotels. The goal is to serve this community. And so those are the kinds of areas where you can save many thousands of dollars. And we're talking about that So there aren't restrictions here. We're very interested in investing in our staff and investing in training and investing in the competencies and technology we need. But there are areas where we can be smart about money, which allows for far more options when it comes to something like the investment of a building. I want to just share also that we anticipate the cost of building to go up. So if we weren't just, and if we didn't start the process now and we waited a year or 2 years, the cost might be much higher. So that's one of my concerns. But I wanted to discuss with the board because I really want this to be a transparent process and I don't want anyone to feel that we're being committed to a process simply because it's something we said we were going to do. So, if the board has thoughts, I'd certainly like to hear them now because we are hitting on some deadlines that are important for us. And we won't mention those deadlines. Ryan can do it so I don't steal anything. Are there any questions from the board or concerns?
I would just make mention that there should be thoughtful consideration to the networking and computer Wi-Fi connectability of the building in any design process that improves the building, takes into consideration IT support and or IT budget, because obviously the people working in the building benefit from connectivity, and sometimes it can be a challenge. So those things are easily overlooked in design phases and probably shouldn't be.
Well said. In fact, I wish it was just technology that was our issues, but we found that the use of our big expensive generator only electrifies certain parts of the building. So we've worked on fixing that too. What's the point in renovating the building if it actually doesn't solve some of the problems that we found in the original building? Also, Dr. Atterbury had brought up not just the purpose of a renovation for aesthetics, but safety for staff, accessibility for our clients, privacy for people who are receiving HIPAA privileged medical care. It's really a fine option for us. But again, I want to be thoughtful with money, and it is an interesting time, and there will be cuts coming. I'm certain of it. But right now, our budget supports this, and the budget the board passed with our interest makes us whole. So I think we're in a good place.
If I could just add, as we've looked over this, the health district needs over the last couple of years. I mean, we started out with the idea of looking at a whole different building and not just to replace this one, but to add on to what we're currently having. So what we're looking at right now, I think is it's much more modest. It's thoughtful. It's trying to be conservative, be careful with the money while yet still trying to achieve the goals of providing all the things you just mentioned, like more workability for the staff, obviously a concern for privacy issues, which is an issue. It is a concern. And so, the project continues to have my support, and I appreciate your efforts to look where, save money wherever possible and be cost conscious, but I think it is a worthy project.
Thank you.
Any other comments? I would just like to say that I supported it as well. I think that not only the workability of staff, but the safety of staff in public settings is always something worth looking at. I think that's important. But also privacy to the clients coming in from receiving medical services or doing certain testing. I think protecting their right to privacy is equally important. So, and I think they've done a great job of paring it down to even the best that they can get for the dollar here. Very wise, and I support it.
It won't be fancy. I also did want to share that we've been in this building since, is it 2007?
Yes.
So if we use that as a barometer, if we're looking at a 20-year life cycle, that's a very small investment. And so I visited a small community recently, and they were talking about an addition they made, and the addition, which was small, cost more than the original building. And that's what I want to avoid. It's getting to a point where it just seems like an obscene amount of money. But I do also want to share that I recognize not just the thoughtful consideration by the board, but the optics of investing in a time of great uncertainty. So thank you for your continued support. And that's all for me, unless you have anything else.
Anyone? Right. Thank you, Mr. Fresco. We move on to Chief Operating Officer Ryan Iba.
Okay, so adding to the building remodel, so we are in the middle of the sealed bid process, and that will close on next Friday, April 4th. Where we'll open up the sealed bids, and then we are prepared to move forward with that. We'll be working closely with our architect on making that decision. We also have 2 unions here at the Yakima Health District, and so the collective bargaining agreement for both those unions do expire at the end of this calendar year. So we will start collective bargaining in the middle of June. We'll start that process. We also we've recently lost a public health nurse, and so we'll be hiring. We're currently advertising for a public health nurse position. So if you know of anyone, send them our way, because we have a lot going on in the Yakima Health District nurse for. And then finally, for our emergency preparedness, we are going to be attending the Pacific Power Public Forum on April 28th. To start preparing for wildfire season and power shutdowns that happen with those wildfires. And then also we're part of a statewide FIFA Public Health and Medical Committee, which is managed by the Washington Emergency Management and the State Department of Health. And then we're also, as we mentioned before, that Yakima is a fan site, and so we are part of a subcommittee for that to start preparing for the FIFA World Cup, that fan site. This committee will be a conduit for local planning and preparation and state level preparation. Active in that planning.
I'll share a little more about the FIFA World Cup, if I may. So the county, the city, and several other people, agencies in the area are working on this together. Kathy Kramer from the CEO of the State Fair Park is heading up the committee because they'll be using their facilities to provide for the program. Just for your information, it is an opportunity for communities to be able to watch the FIFA World Cup on large screen, groups together, families together, teams together, and really enjoy it. We have 6 games coming to the state in 2026, and all of those will be part of the fan zone activity. And so it's all in the planning right now. We're going to be doing more public announcements. FIFA is very, very restrictive on their copyrights and information. So we have to wait until they tell us exactly what we can and can't say as they begin to operate, just publicize that this is going to happen in a larger way. So I'm just very excited. Yes, they'll open up toward the end of the year, the lottery site for tickets at Lumen Field, and I'm sure they're not going to be cheap. And so many of the people in our county who love soccer, will now have the opportunity to watch it for free. So we're very excited about that.
Okay, and then also I just wanted to add too on the building remodel, since the sealed bidding does open up on April 4th, we'll be working with our architect and making decision on the construction company, the contractor, working on the contracts with them. So it's a possibility by next board meeting, we'll actually have started the billing process.
Wow.
When we start that process, are we gonna have to relocate our meetings or?
We're going to try to work around that. So we'll be working with the contractor closely on that. But if we do need to, then we'll let everyone know.
Sure. We're going to Ryan's house.
There you
Cool.
go.
We do have, do you want to share again, the phases and the plans for this?
Yeah, so we have 2 different phases, and the first phase will be this back area, the lab and conference rooms, and then and the help desk for environmental health up at the front lobby. So it's kind of the more forward facing where the public will be going to, and then some spectators will be in the back area. And so Gabby and her staff will be working closely if we need to relocate our front desk services to another location for a couple days while they're doing things in the front.
To Dr. Atterbury's point, Gabriella worked with the team to come up with a mobile birth and death certificate process so that we can stay connected and still provide services to people, but it will be a bit disruptive. We want to support and entertain the board at board meetings, but we really don't want to inconvenience you. So we've got to figure that out. But until we actually, we can guarantee you that there'll be less parking because we'll have new guests and they'll be wearing hard hats, but, and there may be a little bit of noise. But we do want to, we want to play that by ear right now.
That'll all be part of the entertainment.
It will be interesting and it may be loud, but it looks like a lot of work is happening. So the louder it is, the more I guess people are getting done. Well, I hope.
Any questions for Mr. Nakasone? If not, then we will move on to our financial reports from Chase Porter.
Hey, good morning. Financial report starts on page 8, or it'll be up on the screen for you to follow along. For the month of February, we had a loss of 227,000, bringing an annual loss of 184,000. That's a little bit misleading. I'll get to that here in a second. Our allocated budget through February, the revenue is $2.2 million, and our actual for revenues coming in at 1.7. For expenditures, our budgeted for through February is 2.6, and actuals coming in at 1.9. So we're doing well with the expenditure budget first couple months of the year. Next page, please. Moving into the February income statement, there's some large differences in our year-to-date budget for FPHS, Foundational Public Health. That will continue to grow for the first 6 months of this year. We've received Foundational Public Health Services funding in 2024 due to government GASB. We're required to book that revenue in 2024, and this is the result of that. We have this large budget to actual difference that we'll have going through the entire year, but at the bottom of the statements, I reflect if we were actually receiving that money, what that would look like. Coming in under budget, or is there any questions about the FPHS funding and the timing about that? Okay. Moving into the expenditures, I don't have necessarily a lot to note here. We're coming in under budget for quite a few different things. However, we are generally kind of slow at the beginning part of the year for a lot of different things as our BCHP program starts to gain traction for the year, and our EH will start to see more of an uptick in expenditures, especially with the building too, when the building starts to move. Any questions in the first half of the section? Moving to the second half of the income statement. I'd just like to point out down here at the bottom here at FPH. Okay, next page, please, Mariella. Thank you. Would you mind zooming in just slightly? Just so that we can see. Yeah, that's good. So we can see loss for the year. We have 184,000 year to date. However, for FPHS funding, we've brought forward 666,000 from 2024, resulting in a gain of 482,000 for the year. The majority of that gain is our investment income. Any questions about that? That is a little wonky, so if there's any questions, please ask.
Do you want to mention that you anticipate investment income from them?
Yes, investment income has been very strong the past few years, and it actually really jumped up October, November time. However, with the economic environment that we're seeing a lot of downturn in that. We've had a lot of gain in our investment income over the past few years. That will probably not be the case.
So Chase, back to the FPHS funding, if I understand it right, what you're just simply saying is that, we've got the FPH funding, but the 2025 funding we actually received in 2024, it was from.
Yeah,
So
half of
it
it,
doesn't
yeah.
go up as receiving in 2025, but it's because we already got it.
Exactly. And that's what we're reflecting. We're actually carrying over $2 million.
Yeah, and that was a result of the biennium and changing the governor and so forth. And we will see, again, changes, I think, to the FPHS amount, but we're not certain what that will be yet.
Yeah. Okay, moving into programs. Again, the clay section here is the FPHS programs, and you'll see the little T next to that, that meaning the loss in that is due to a timing issue, as we just previously discussed. Unless there's any specific questions, moving into the next page. Again, nothing necessarily specific. We have a few immunization losses, however, expect some Concon funding to come through for that. And then we move into our EH programs for the month of February. We're still very much in the month of winter. I hear that is turning around for them right now as we speak. It's going to be almost 80 degrees today. So
Yes.
so people are getting outside and starting to dig holes. And so that means that's more work for that crew. Moving into the very last page of the programs, and again, it's a lot to do with timing differences and there's water projects going on too as well. Any questions? All right, moving into the last piece, our cash flow. At the end of the month, we have $16.3 million in the bank. I do expect that to tick down, month over month until the month of June, July, when we get another, FPHS flexible dollar, uptick. Any questions? All right, that's my report. Thank you.
Thank you, Mr. Porter. Got a question over there? Anyone? No? Okay. Then we will move on to our health officer, Dr. Neil Bard.
Good morning. A couple of things I want to make comments on about what was earlier presented. The central area of acquisition and dissemination of information like influenza rates and stuff is as Lily pointed out, from the CDC. But there's already been modification and changes in that pathway, so less information is actually coming out this time, making the decisions at our level far more complicated. And it remains to be seen whether that's going to get better or worse or just stay the same, but we're now getting less information than we got this time last year. Another thing regarding flu, Melissa had called the hospitals up and found out that the machine, at least at Memorial, that detects influenza can subtype it as an H5N1, which is then sent to the state lab for confirmation. Yeah.
If it's unsubtypable, then they.
Yeah. So the ability to identify potential strains exists at Memorial Hospital. And if they send it and gets confirmed, then we know we have a case of H5N1 from a human specimen. So far, I'm pretty sure we haven't detected one, which is great. So the news and stuff seems to have settled down. And as the flu rates continue to drop, we'll probably get through the summer without too much trouble. The big impact, of course, is the poultry and the cattle industry, where, you know, milk production and eggs have changed and become more expensive. I want to talk a little bit about which we've been talking about for several months with the TB outbreak, and point out that this is a big partnering thing, you know, so we're not doing this on our own. We're in communication with Tribal Health, the Indian Health Service, the Department of Health, and CDC. We've had several meetings and have another one coming up where these ideas are exchanged. And information disseminating out to local practitioners is going to result from this collaboration. And that's not unusual. This is often the way that outbreak problems are dealt with. So one other item before I get into my main topics, talking about record keeping. The original polio study had 1 million people entered in it, and was all the record keeping was done by hand with 3x5 cards. And all those records still exist at the University of Michigan Public Health School.
Are they legible?
Imagine it.
If you learn cursive in school.
The system sorting, and a card file would have little tabs on it with holes. And each one of those holes, they were staggered, and it would represent a specific question of the study. And you would take a rod and push it through there and pull all the cards out. And it was like let's say all people over 65, you know, there'd be a tab for that. And they just do it. So, you know, computers help a little bit. And the card system doesn't crash. Okay. So I thought I'd take a little different group of topics today. And one of it, I came across a very interesting article in The Economist, which is a very nice journal to read. It's really a little bit more than a magazine, a little bit less than a scientific journal, but they did a article on why hospitals inflate healthcare costs. So it's, you know, we've been blaming pharma, we've been blaming salaries of healthcare providers and benefits and all that. But in the United States, 1/5 of the gross domestic product is shuttled to healthcare. That's twice the average cost from other wealthy countries. But even though we spend more, the outcomes are no better, and the death rates for cardiovascular disease, renal failure, or renal disease and diabetes are higher in this country. So we're really not getting good value. So even though pharma, a lot of drugs cost a lot, insurance company costs are a lot, and the middleman who doesn't really even need to exist, but costing us a lot of money. Don't even compare to what hospitals collect in revenues for providing their services. The total for American hospitals, not-for-profit, for-profit, university, community, $1.5 trillion in fees. So that's a good target. Pretty big, can't miss it if you go after it. 3 times the amount, so that value is 3 times the amount spent on medications, all medications, just to give you, put it in perspective. This revenue collected has increased 250% since the early 2000s. Those other, this has been an area of tremendous expansion. Most of the healthcare fees that are currently in place, about 70%, are on the fee-for-service model. So the more you do, the more you get. And a lot of people blame doctors for this, but like Dr. Atterbury and I were talking the other day, most of the doctors we know are too busy to kind of game the system. It's really, I don't think much of it falls on the doctors, but it's the system, And, I've been going to a clinic for 24 years and I never had an excess charge. My insurance will cover everything. That clinic was bought by Optum, which is a subsidiary of a big healthcare company that shall remain nameless. And I am getting bills, not for much, but I'm getting bills that I've never gotten before. And that's because they've raised the charges. Medicare and supplemental don't pay those extra charges to pass on us. And you can imagine somebody that can afford that a lot less than I can. So that's changed recently as there's more and more consolidation, both in not-for-profits and for-profits, and that's driving costs up as competition goes down. And what further adds to that is there's no transparency in pricing. So you could get a cardiac cath in Dade County, and it would cost $21,000. And you can get it here for $6,000, same procedure, same materials used, same machinery used. And that disparity in charges is one of the things that the government is trying to fix, but they're not having a lot of steam. The head of steam is not really pushing that along very well. It's certainly something, again, big target to go after. Now, what they want to replace fee-for-service is something they call value-based. And it sounds like a good idea, but if you go online and read up about all the little sections on value-based care, I think that Dr. Atterbury and I both experienced how difficult those implementations can be and how generalized they are. I'll give you one example. There is a program to decrease the rate of death from sepsis, which is an overwhelming infection that people can get from bacteria, for example. It can happen with other viral infections as well. So they have a set of criteria that are time-based. And when someone comes into the emergency room, they have to have these things done in a certain amount of time. And if they aren't done, they get dinged in reimbursement. Okay. The problem is that the criteria are not universally agreed on by the physicians who take care of the patients, yet they're being dinged on that. And these criteria should change over time, but there's a big lag. There's a really big lag. So the implementation of the idea is not as easy as thinking it up. And that's adding to, a downstream problem. So it's like squeezing the water balloon. You change something here, it gets worse over there. So as a result of these criteria, antibiotic use has gone up in the emergency room. And that creates a whole nother set of problems with antibiotic resistance. So everything's connected and you can't just barge in there and make up a new program without taking some time and reevaluating. I'm sure there's more work that's going to be done, but again, there's like for sepsis, there's probably a 3 to 4 year lag in the latest information that's acquired from studies to the implementation by CMS. So that's just a big overview of healthcare costs, and all of us are going to be affected by this. So some of this has led to the sort of acquisition of hospitals and then the failure of the parent company. We experienced that here. So the original company that bought Providence was bought by another company, which then went under. And another hospital in that system was Deaconess. So Deaconess was taken over by Multicare. So were we. So our hospital is being controlled by decisions from Tacoma. which may or may not jibe with what we need. So I don't know if we or myself or any of us can influence that, but at least the hospital's open and patients are going in and getting cared for. But that's not them specifically, but that whole concept is adding to healthcare costs. Okay. So enough about bad news. Okay. Good news is, it's not really good news, but.
Thank you for qualifying that. Dr.
He's polishing his comedic skills too.
As opposed to something we can't do anything about that other people have to do something about. The measles outbreak still continues. And some of the interesting data, the good news is Yakima County has the highest rate of vaccination for measles in the entire state. That's really good news. So I don't expect that we're going to see cases, homegrown cases. If we see anything, it's going to be coming in through the airport and there are people moving out here. But if they come out here and they do some business out here and they have measles, our vaccination rates are high enough to prevent an outbreak of measles here. Where those outbreaks have occurred is where the vaccination rate is below 95%. That's what it takes to maintain very low or zero cases. And that's where we were from 2000 to about 2010. So there was no measles cases in the United States except those that were imported. And because of the 95% and higher vaccination rate, no outbreaks could occur. Last year, there were 16 outbreaks. 69% of all the cases of measles were related to these unvaccinated people in the outbreaks. So there were other spontaneous cases, but most were that. And the same is true for this year. As of March 20, there are 378 cases of measles in 18 states. And now those outbreaks account for 90% of the confirmed cases in 2025. That's to date. It's only 1/3 of the year's over, and we've already exceeded the total cases from 2024. 95% of the patients who are getting infected are unvaccinated or have unknown status. 3% of those patients have only had 1 dose of vaccine. And 1 dose of vaccine is pretty good. 2 doses is a little bit better. And people who have had measles before the vaccine was available are also protected. 17% of the people who have been involved with measles cases have been hospitalized, and the largest percentage of hospitalized have been less than 5 years old. There are 2 deaths, 1 confirmed and 1 awaiting confirmation. So of the patients hospitalized in 2024, 40% were for isolation or management of complications of the disease. It's really very predictable what happens with measles. It's almost always a 14-day incubation. So that creates a problem. Somebody with measles comes in and it's before the onset of the symptoms, which for a brief time they're contagious. They don't know they're sick and they're exposed to other people are exposed to them. And then that's how measles moves along. And I told our group about a book that's written that recently was published called Booster. And it really details how all the epidemiology of measles was figured out, and it was all from a group of islands related to Denmark. And 2 medical students went out and did all this epidemiologic study, and the islands were isolated except for the mail carriers. And they were able to time exactly when the mail boat came in to the onset of native infections, and it was 14 days. Really nice reading if you're interested in that. So the infection rate, or rather the immunization rate nationwide has dropped to 92%. So unless the vaccination rate can increase, we're going to be in for measles outbreaks over and over and over again. And I guess eventually we'll run out of people that are susceptible if we can vaccinate them, and then we'll get back down to 2,000. And if we don't get that number out, we're going to still have cases because people come in with measles. You know, they come into this country with measles where the vaccination rates are far lower. So, be happy to entertain questions. Otherwise, finished.
Dr. Barr, I'm just curious, do you know what you would correlate to why our county out of all 39 counties has one of the highest percentage of immunization?
Yeah, We have two large federally qualified institutions, farm workers and neighborhood health, which cover a lot of the highest risk people, and their immunization practices are excellent. We also have a group of pediatricians that are extremely proactive in getting vaccinations to the kids that need it. And we have a nice program that's been run by, the fundings come from different organizations where there's outreach and vaccination clinics are set up, and people are will volunteer to do those vaccinations. So I think all those add up to an excellent vaccination rate.
Thank you.
Just one thought about the article about healthcare costs. You know, when 20 years ago, I started at Sunnyside Hospital. It seems to me that I remember that at that time, healthcare took like about 13 to 14% of the economy. Now you're talking about 20%. Is there anything in the article about cost of liability?
No, there wasn't, but that's always been a problem, you know,
Yeah.
people ordering extra tests and things. But I think that when you get, you know, there's a few high profile cases that collect many millions of dollars, but they don't happen that often. And it's a good question too, because institutions can actually do something about malpractice costs. And I was at a presentation a number of years ago where they took a very different approach at University of Michigan Hospital System. And when something was discovered, something went bad with the patient, they already knew that unhappy patients were usually ones that brought lawsuits, whether there was actually malpractice or not. So when something went bad, people from this proactive office of sort of like ombudsman, they would go and talk to the patient. They tell them what happened. They tell them why it happened after investigation, and they told them what they were going to do about it. And their malpractice reserve was able to be decreased by 70%. So all of a sudden, several $1 million were now available for investment in the organization. So there are ways to deal with that. But overall, those costs aren't that great when you talk about, you know, tests, procedures, daily hospital rates for bed, you know, admission rates, you know, emergency room stuff. You know, you can go to an emergency room in Washington State with flu, you know, and get a bill for $9,000. I'm just making that number up, but I mean, it's ridiculous what the emergency room charges can be in some hospitals settings. So.
If I may just add to your point, Commissioner, it's not just the cost of litigation or the coverage, it's this, I guess what I would refer to as litigation anxiety.
Mhm.
So additional tests are run to make certain that you're covering all bases, which flies in the face of what insurance companies want to pay, which creates a system that's in conflict always. And you have essentially sole practitioners who are reliant on a system that who nonetheless are also at risk as practitioners. So it's not ideal to be a practitioner these days.
Well, liability is an issue everywhere. I mean, I can tell you that looking at our county budget over the last couple of years, we saw a $2 million increase in liability costs for our road department. Believe it or not, our road department. So anyway.
Well, I would just add one thing. I would just add one thing, Ladon, to your comment, and that is, and to build on what Dr. Bark said. Normally, when you talk about healthcare consolidation, we'll refer to this concept of economies of scale. As companies got larger, their ability to buy bulk product or bulk supplies became cheaper, and therefore you gain savings. The problem that we face nowadays in healthcare, though, is that the consolidation is leading to near monopolistic areas of consolidation in many, many areas, this one included. And when you see monopolistic consolidation, you start to see a loss of the elasticity of supply demand curves when it comes to economics. And therefore pricing doesn't necessarily reflect what could be, but reflects more of the monopolistic entity that you're dealing with. And they can put prices wherever they want because there is no competition. Some of the things that have far-reaching effects on this would be things like our certificate of deed laws in the state of Washington and the ability to make competition for the healthcare systems. They're a burden for individual practitioners to overcome. They're a burden for competition in the market that would otherwise probably lead to a decrease in pricing for the end consumer. But the way in which the system is built and regulated makes that impossible. So I would just add to Dr. Barg's comments that sometimes the 800-pound gorilla isn't your friend, but oftentimes in this modern environment, it's a necessary evil because it is terribly expensive to run a healthcare system. And those costs are passed on to somebody, and that somebody is every consumer and every insurance company, who in turn passes it on to every consumer. So I would just say that the costs are borne by the people who are in the system getting care. And that's unfortunate because those are the people least able in many cases to afford it.
And just to augment what Dr. Atterbury said, private equity firms, when they buy hospitals up, they often cut costs, but the costs, that those savings are not passed on to the patients. Universities and other large not-for-profits also make a lot of money, and they don't turn it to investors. They put it back into the organization. They build more buildings, they hire more people. Again, the savings aren't passed on to the healthcare consumer. So it doesn't matter where you go. It's not going to be cheaper.
Any questions for Dr. Barg at this point? Comments? Thank you, Dr. Barg. Are you complete?
I'm done. Thank you.
Okay, thank you. All right. Then we'll move on to disease control. Melissa Sickberry.
Good morning. Touch on 3 topics today. I'll do measles, tuberculosis, and our flu, of course. So for measles, is following what Dr. Barg said. There have been 2 cases in Washington State. One of them started in King County, which was somebody who had international travel, had multiple settings where they could have exposed other people. So part of the things that happen in local health departments and public health is we receive notification that there is potential exposure at these locations that they defined. And our role then is to notify individuals, or if we get calls from providers, it's part of the screening, did you travel to this location during this time period, monitor for symptoms, which is then how they identified their second case, which was in Snohomish County, on that individual who then had no exposure settings, did not expose anyone else further from when they were infected with measles. So it's just the way that public health works. The things that are in place to help prevent the spread further in the communities is just the State Department of Health being notifying all of our LHJs in our process and monitoring our patients. So we did have one notification of an individual, but it turns out the time frame that was identified was actually greater than what the actual exposure was. So we were able to eliminate that potential exposure. For tuberculosis, we have a lot of active cases going on. So for Indian Health Services, they're currently managing 9 active TB cases, and Yakima Health District is managing 7 active TB cases. These are active or suspected active TB cases, so 16 in total, which is a large number compared to what we would normally be managing. I can't thank Catherine and her team enough for the partnership and working with them and Indian Health Services to contain the outbreak happening in the Lower Valley area. So thank you to you and your team for that. And then on our flu numbers, Lillian touched on it. We have had 12 flu deaths for Yakima County residents so far this flu season, which goes from mid-September as we first started, or late September when we first started monitoring the numbers. And that'll go until we're still monitoring because the activity is actually still high. Normally it would decrease by now. Still high activity. No pediatric deaths, but there have been pediatric deaths across the state.
So are we seeing this mostly in older adults, and are we seeing it in group settings like nursing facilities?
It's a mix of both. Our cases are either immunocompromised or 65 or older, but no pediatric deaths. And that's the end of my report, unless there's questions.
Question on the flu. Do they still, here locally, and then does the CDC still report new cases and whatnot with pneumonia cases? Because they used to, I know the
Did they
CDC.
separate them?
Yeah, they used to be together, all lumped together at the CDC. It was like flu/pneumonia.
For deaths?
Well, I
Or-
think both for cases and for deaths.
No, not to my knowledge, because the influenza and pneumonia, neither one of them are reportable on their own, and the only thing that would be notified would be an influenza-related death. So when we get notified that there's a death that has influenza on the death certificate, what our public health nurses do is request the medical records, and we do a chart, abstraction to identify, were there other contributing factors? Was this actually an influenza death? Was it lab confirmed? Similar to what we did with COVID, but I've never seen pneumonia be in there as a contributing, well, potentially a contributing factor, but not as a reportable linking it together.
So they're, neither one are reportable by themselves, is that what you said?
Correct.
So then they're
It would just be
basically
the deaths that are reportable, just influenza death.
Oh,
But an actual like influenza case,
Yeah,
so
so
like
they're-
salmonella is notifiable, but influenza case is not, only if it's a death. Then it's reportable. We keep track of the statistics through our local hospitals, just so we can monitor and do surveillance on what the activity looks like within our community. Like Lillian said, just so the community is aware and they can make their decisions on how they want to protect themselves and what they choose to do. And it also helps drive what the hospitals do for their requirements on their policies.
Just to follow up on that, Daily, the influenza diagnosis, you're probably gonna miss the large proportion of them if you just look at hospital data. Urgent cares and the likes are going to capture an even larger percentage. I think some of which do rapid testing for influenza A, others don't. And so that would be a data set that would be incomplete and error prone if you used it to make analysis, because you're not capturing the true end.
Yeah, we're really only capturing the ones that are sick enough to go to the ED to get tested, not the urgent cares. And a lot of it's done on point of care rapid tests, which then doesn't get reported to labs. So then it would take the manpower of those clinics to actually put that, send us that data, which is not feasible at this time with the healthcare shortage and that.
So really quick on the TB stuff, when you contract TB, how long does it take for you to get over it?
That varies on how quickly you receive treatment. Dr. Barr can probably answer better. It's a long treatment process, but it really, sometimes you can just brush the symptoms off. It's just a cough.
Well, I guess what I was getting at, if we have 16 cases in the county, I thought it was very like heavy, intense, where like you had a health district person had to go to someone's house every single day to administer whatever it is that we need to. And so at some point that becomes very costly. I imagine. Of 16, if we're alarmed at 16, because if it gets to 100, then all of a sudden we don't have enough funding to do the things that you need to.
I wish Chase were still in here, he'd be able to answer that, but yes, treatment can go anywhere from 4 months to 12 months, depending on the type of TB it is. One of the things that we did implement several years ago was the video DOT. So for that initial intensive phase, we do have to go out and monitor those patients daily, because the medications that we give our patients can cause liver toxicity and other side effects. So we do go out and we monitor them until they've developed and shown that they're stable on this medication. There are no side effects. Then we can spread our actual in-person visits. And so we do video DOT. So
Gotcha.
that's a minimal cost to us. And that's something that was cost saving. I mean, you think about the time a nurse is driving from, way out in Tieton to the Lower Valley. It's very costly. So that's definitely save time. Indian Health Services, for their patients, they are the ones that go out and provide DOT. They are not currently doing video DOT, so they're using a lot of resources, but something that we're working together to figure out how we can help them to have a less impact. But it definitely, I don't know if you want to speak to the.
Sure, I can
question or
address
not.
that. First of all, the reason we did the video DOT was simply because it's a large geographic county. And it wasn't just the cost, which was staggering, but also the lack of ability for one of our staff to be available to do other things. So it literally meant that you might have a 10-minute intervention and it was taking 2 hours to get there and back, which doesn't meet the standard of good service.
Yeah.
So that helped us. To the question of cost, full transparency, the state law requires that the county ensure that TB is cared for, which is also, we receive support from the community for that. But one of the reasons that we're smart with money here and have options upon options is this: if you have a circumstance where it becomes a very large cost, we want to have ample room in our budget to address it. And there are other counties that haven't traditionally had TB outbreaks, but we have. And that's been something that's been consistent throughout my time here. So we always plan for the worst and hope for the best.
Yeah.
Which is why at the end of the year, we often have additional savings because we've anticipated what we might need so that we don't have to open up the budget again, which is again, an option in our state, but we choose not to do it.
Understood. Just keep the numbers low, Melissa.
We're trying.
Pressure.
Well, and if I may, I also want to share with you candidly how this works. That's another thing that Dr. Barg and Dr. Atterbury and Mosley can certainly address better than I can, but it sounds bad that we have an outbreak. It's actually addressing an issue. It would be worse if we were not taking it this seriously. It would expand exponentially, and then it would be national news. Because then we would need the support of the State Department of Health, and then there would be regional concerns. So addressing it now means it doesn't spread the way it could spread if we were not in a position to handle it. So as an example, if we hadn't implemented electronic DOT, I think we'd be in a bad situation right now.
Yes, we would be in a very bad situation.
Did I
And that's
do?
why I really appreciate this partnership, is because the more we can work together and confine this outbreak, I mean, it just has a huge impact from individual health to communities, health for healthcare systems, financial resources, all of it, so.
And it's a good opportunity, if I may, to pay respects. Each of our board members has been invaluable to us and available to us. We've always been grateful over the years. Recently, Lupita was very helpful to us. She would never volunteer, that she was instrumental in assisting us with getting us support and information regarding translation services for people who were coming, which was very helpful. But Catherine, being a member of our team, but also being a committed public health servant and working with tribal health has really been invaluable with regard to numerous things, which includes services to those who have addiction issues and harm reduction. But the partnership is ideal, and it's not always the case. So I'm really grateful for people's willingness to work in partnership on behalf of this entire community.
Our partnerships are going for us for this circumstance, which helps.
And let me just add to the answers that you got already, Commissioner Curtis, but when there's TB exposure, a large proportion of the patients don't really become sick. It's dealt with and it turns into what we used to call latent TB. So it's present in the body, but the body's controlling it. Now, later on in life, that could emerge as a reactivation TB, which is a real infection. The patients get sick. If they're untreated, they will die. And right now, since COVID has dropped, the #1 cause of death from an infectious disease in the world is TB. So if you identify the patients who have TB and you institute treatment, they will live. So that's why it's so important to identify cases, see who the contacts were, and go out and test the contacts to see if they've had exposure. If they had exposure, there's a way to treat them to greatly diminish the chance of reactivation later in life.
Thank you.
So that's our basic plan, and everyone else does the same thing across the country. And they're all these TB. Right now, probably my biggest hours put in are on TB. And, before this year, I think I haven't seen 16 cases of TB in the hospital system. And hopefully we won't see much more, but we're working hard to make sure that doesn't happen.
And we did send out a provider alert yesterday on the situation that's going on, which just advises providers on what they should be looking for, what steps to take, when to contact us. There's another added, because we are here for a resource to our providers, so it is something that's on the forefront of the provider's mind now. We will be getting additional calls for screening, if it falls within a certain area, but at this time, it's better to be overcautious than to let somebody slip by undiagnosed.
And if I may, also the provider resource website, and I'm sorry to go into detail, but again, that's a communal internal process. It's a multi-department team effort. So it's not Melissa in the middle of an outbreak having to make certain that goes out. That's Lillian and her team working on that. It's with direction and support from our physicians. It's certainly under the direction of our nurses who are dealing with it, but that's a system that we built in partnership with what was before Foundational Public Health Services with Tacoma Pierce County, which was to create a way that people didn't just have to call us, because when I first came here, we had a nurse on duty, and literally charge nurses from the hospital would call in the middle of the night to say, how do I handle a TB case? Or how do I deal with this? It was literally that labor intensive, and mistakes happen. So that was one of the reasons that we created the provider resource website, was to not only have information timely and well, like a TB outbreak, but also have protocols and care plans and best practices available 24 hours a day, which has really become invaluable. And I won't bore you with the fact that we have a new way to get that out, but we used to have a fax system that also used to bring us to our knees. Back to technology. So that's for another time, but we've moved exponentially past those days.
That's all for me. I'm sorry, unless there's.
Thank
She got excited about the issue of the fact that.
Well, you know, what comes to mind is, I think we sent out a survey and a lot of them would prefer fax. It's really interesting. So we have multiple ways that we do fax, email, provider resource.
Mhm.
Our provider, we do a monthly provider update meeting with our nurses every month, so we have multiple ways to reach.
The healthcare system is solely the people keeping the fax business alive.
Oh.
Unique thing to the healthcare.
How do you find out about lunch? They have to fax you the lunch
Well,
special.
you know, it's because you can't email electronic health, or you can't email records. It's because of HIPAA, so the only way to securely do it is through fax, so it has definitely kept the.
number.
Yeah, like, so it's the wrong number. But yeah, it is definitely, healthcare has definitely kept faxes alive.
Any further questions or comments for Melissa today? If not, thank you, Melissa. We'll move on to our environmental health, Sean McGee.
Morning, everyone. So a couple updates. We are approaching our busy season. We're already starting to see some increases in certain areas. But we're making a big push to get our annual pool inspections done. Because our seasonal pools generally open up around Memorial Day, and we have quite a few seasonal pools to get to over the course of the summer. And of course, our camps will be coming online here soon this summer, and we'll have some work to do with them in preparations for wildfire season. We have a large list of sanitary surveys to do this year. We have almost 40 of them. Those are evaluations of large water systems. A lot of our farms and temporary worker housing facilities have these water systems that we go take a look at and identify any potential issues.
Every year, every year, or?
No, they're on a 3 to 5 year schedule based on how well they're doing. So we do that on behalf of the State Department of Health. And then we're starting to see a steady uptick in our septic permitting applications, our adequate water determinations, and our requests for well site evaluations. So people are getting ready to build. So we're getting prepped and ready for that. And we're seeing increases in our temporary food event applications. So busy season is upon us. I feel we're really prepared and ready to take it on as we're getting all of our other types of inspections that we can do at our own pace, wrapping up a bit early so we can absorb the increased workload for the busy season. Another update is our Certified Food Protection Manager program that we have recently implemented into our services. We had our first testing event a couple weeks ago, or over the last couple weeks. So our first course, we had 54 sign up, which is absolutely great. We did not expect to get that many. We had 20 sit through the course for our English course and 34 for our Spanish only course. So far, they haven't all tested yet. They get 2 attempts at it, but I'd have to look at the updated numbers. I was on vacation for a couple of days, so forgive me, but we're right around 90% pass rate. which is about 20% over the national average for pass rate. So we spent a lot of time fine tuning the course, and especially on the Spanish speaking side, the video was just dubbed over and subtitles. A lot of it didn't translate very accurately or very well. So we implemented some of our own slides to support that video to get the message or the curriculum a little more clearly come across more clearly and better understood by those folks. So I think it's helping quite a bit as our pass rates have been really impressive. So we're glad that that's going smooth, and we'll here in 2-3 months have another round of people who will sign up for the course. The goal is to have those happen quarterly. And the last thing I have is April 1st, the new on-site sewage Washington Administrative Code takes effect. Well, the bulk of it, there's a few pieces of it that don't go into effect until April 1st of 2027. But we've been having some trainings and some kind of test runs in different scenarios on the portions of that WAC that take effect in a few days, to have our staff ready and prepared to go through the septic permitting process and site evaluations under those new rules, which has a few new tables on different soil types and depths that dictate what type of septic system a certain property can have. So we're ready for that as well.
Ready for any April 1st jokes when they come out?
I don't have any yet.
John Acela?
Oh, yes, Sella. Fill in any gaps that I may miss, but we're, I believe it's the end of the day in this afternoon.
This
It goes
afternoon.
offline. So we've been advertising that Acela will be offline, so there's gonna be challenges to issue permits for temporary food events, renewing different annual licenses, and things like that. So we've had that in our lobby. We've put that on social media. I believe there was an article put out in the paper. So we've tried to get that information out to the general public as best we can. There's really no way around the inconvenience of our permit management system being offline. So, but we have our pens and notepads ready to take notes for people that when it comes back online, we can do a little bit of catch up and get them the documents they need. And I believe it comes online April 1st.
That's Yep.
Yep.
That's what I thought you were gonna start talking about April 1st. What's going on?
Is that it?
It better be. It'll be a conversation.
Funny joke. It's not a funny joke.
I gotta say, we did do a really good job because yesterday we had a full lobby of people bringing in applications, so I think the public was aware of the information that we were spreading, so.
Yeah, it's been a busy few days up front.
And this isn't aligned also with the county, so.
Yes.
Yeah.
We made, this is going to be, a heavy lift throughout government in the next few days.
It's gonna be either really hectic or really quiet.
To be fair, our team really pushed hard for a weekend implementation. It was not great. We're really hoping that a lot of this could be accomplished at night or on the weekends to ensure that we didn't impose this on the public, but there just was no way around it, as I understood, so.
With the vendor that we selected, right? Yeah, okay.
Yeah, my goal is always that we can do these things it's like construction late at night on a road when people are not moving, but it's essentially construction in rush hour. Right?
Yeah.
But that's the way it is. So we've planned well, and I'm really grateful to the team again for we've overindulged in communication, so it's good.
I do want to add to your pool inspections,
Mhm.
noting that the Martin Luther King Aquatic Center will be opening in June. So you'll have
Oh, yeah, we'll
very
be out
excited
there
about
to check it out. I believe we usually go do a full walkthrough with the State Department of Health, because they approve the design plans and all that for aquatic facility. So we'll get a really in-depth tour of like all the treatment systems, the piping and all that, so we know what we're looking at when we go out there for an actual inspection. So looking forward to it.
Yeah, we are too. Thank you. Any questions for Sean this morning? All right, thank you, Mr. Mickey. We'll move on to public health partnerships with William Bravo.
Thank you. So a couple of updates in terms of things that were expected to sunset due to the COVID-19 funding ending at the end of the fiscal year. Two things that will be sunsetting, the first being the Caravan. Caravan was the Department of Health's mobile vaccination services. That Caravan has been placed for several years, actually after the federal vaccine site was taking place at State Fair Park. That model that we implemented here in Yakima in terms of going out into the community and providing vaccines was then adopted by the State Department of Health, which created the Caravan. But unfortunately, given the funding, it was expected that that Caravan will no longer be in place to offer vaccinations specifically. But in good news, we were able to utilize that Caravan here in Yakima this past year for a total of 28 events. And in those 28 events, we were able to offer 761 vaccines to a total of 486 people. The majority of those were actually childhood vaccinations, so routine immunizations, those being 434 of those. And then between COVID-19, there was 153 people that received their COVID vaccine through those mobile clinics, and then 210 flu vaccines that were implemented. So even though that resource is no longer available, we were able to utilize it. We were able to advocate for Yakima to continue to use it. And we are still in communication with the State Department of Health on how we can build off of that model rather than just have it go away. So it's unknown what that will look like in the future, but at least we know we were able to utilize it while it was available.
Lillian, I shouldn't think of this Caravan as like a physical like asset, like a car or a mobile unit sitting in a parking lot somewhere.
No.
Okay.
No. They come with their tents and all of that,
Yeah.
and it depends on the state, which type of subcontractor they utilize. So hopefully we'll be able to work with them to see how we can keep that going, but as of right now, it's not possible.
You mind sharing though, that the whole genesis of this started with us bringing services to the people?
Yes, and so again, the reason that the Caravan started was back during the pandemic when we were able to host the FEMA mass vaccine site is what we called it. And we were able to offer the idea to not just keep it at the Sundome, but actually go out into the community at the Fiesta Foods, at different community centers, and have that mobile component. So we were very happy to see that scaled up and utilized across the state for the last several years. So we won't let it go because we hope to develop it. So we'll make sure that we see it through for the future. And then the other asset being the COVID-19 and flu test kiosks. As you recall, a couple of years ago, the State Department of Health allowed Yakima County to have this kiosk or a vending machine. We placed it in Sunnyside, specifically at Fiesta Foods. So it has been in place for a little over a year now. I unfortunately don't have numbers to share. I'll have those for you next month in terms of how many COVID-19 and flu tests were given out to the community. But over the past year, when we've seen an increase in flu and COVID activity, we know that people go there and get those test kits to make sure that whatever they're feeling isn't COVID or flu and they're not passing it on to their family members. So we know that it was utilized, and I'll have specific numbers for you next year, but they we will be able to offer those tests for another week, and then the Department of Health will be picking up that machine April 1st. Lots of things going on April 1st.
Was that also one that had Narcan in it?
No, not that one. So the naloxone machines are still in place. They currently still only have naloxone, and both those being at OIC and at the Yakima.
Why haven't we pivoted to put more stuff in there?
That is a possibility. So that would have to be my understanding that the board decided that we would just need to review that. So at this point in time, the organizations haven't necessarily offered wanting to purchase those. So that is possible. It would just be, we need to figure out who's going to purchase the things that are going to go into the naloxone, into the vending machine, and then bring it to the board for that awareness.
You also have to be careful that you're not distributing the prescriptions for naloxone are under a special non-prescription necessary status, whereas other things you might want to distribute might not be under that status, and therefore you can't openly distribute them without a physician involved or a practitioner of some type writing a script.
Yeah, and then just for context, typically in other locations, people would offer things such as hygiene kits, condoms, pregnancy test. I mean, really, it's whatever the agency or organization wants to put in those. So that is definitely something that's possible. And then last month, there was some discussion around the substance use prevention campaign. So I did want to just to remind the board in terms of the youth-based campaign, just to reiterate, the youth-based campaign specifically is not a new campaign. It's a campaign that we had developed last year with Yakima Neighborhood Health Services. And again, that was at the request of having youth-based messaging. So working with the youth to create the actual message to give to other youth. And what they had came up with was called the campaign called Escape the Escape. So unfortunately, last year, we really didn't have that much funding to do anything more other than to encourage the youth to come up with the tagline, to come up with some artwork, but we were never able to share it with the public. And that's what we're doing this year, is taking the campaign materials that were already developed last year and disseminating them more widely. So again, all the imagery, I believe everyone's already familiar with, but I'll be more than happy to share that so you can see what the artwork was that was created by the youth and those messages as well. But I will say, given that conversation, the CEO from Yakima Neighborhood Health Services did reach out specifically to Commissioner McKinney, and she invited Commissioner McKinney to go participate in a meeting to learn more about the services that YNHS provides. Commissioner McKinney did also invite our other board member, Alicia, to join that meeting, and I believe that'll be next week. So I'm sure we'll have more to share after that. Any questions?
When you talk about the distribution of the messages this year, what's that gonna look like? Or what do you hope it looks like?
Yeah, so the distribution would be that larger multimedia campaign being the billboard will be a portion of it, just so that there's community awareness. So the actual imagery will be targeting the youth in terms of it's going to look and feel like something that a youth would want to look at in terms of not utilizing substances. But most of it will be working with the Yakima Neighborhood Health Services, the space. They have buttons. I mean, it's all different types of media that's more designated to the youth specifically. So there are going to be some radio spots, a couple different social media posts to show again imagery and art that was created by the youth in terms of what resonates with them on being encouraged to not utilize drugs. But yeah, so it would be all the normal channels that we would use.
Any other questions? All right, it seems that April 1st is a very interesting day coming up for a lot of reasons. And I will tell you that our next council meeting, statement at the close of the last meeting that we are open to April Fool jokes. Okay. Then we will go on to our community programs with Gabby.
Hi, good morning. So I have 2 updates today on developmental disabilities and front desk. For developmental disabilities, March is National Disability Awareness Month. So our team collaborated with Lillian's communication team, and we launched a Feel Good Friday social media campaign. This campaign was released every Friday of the month, highlighting inspiring stories of the developmentally disabled clients that we work with, showcasing their jobs and how they're integrated into the community. Additionally, we featured Jennifer. She's a program manager at Elmview, one of our providers. She was on Coffee with the Health District segment, and she shared valuable information on how they help these clients obtain jobs as well as community inclusion. And this segment was held in English and Spanish for our community. So it was very helpful to show the services that we are offering, of course. And yeah, it was just a really great campaign. And thank you, Lillian. Your team did a great job. It was very professional. And I hope that you see it on social media. As for our front desk, like I mentioned last time, we are fully prepared for our Acela shutdown that is happening today. And not only are we prepared for the shutdown, we're prepared for when it opens on April 1st. There's going to be a lot of work around that, and we are preparing ourselves to have a lot of people coming into our lobby just because a couple days off, it's going to be a lot of work. And we're ensuring them that we have other services available as well. So that is all my updates. If you have any questions.
Thank you. Any questions?
I'll just add the Coffee with the Health District segment as a reminder. It's something that we do every month where we highlight some of our community partners, and we do have those available on YouTube as well. So I'll make sure to send out the link in case you guys have any ideas. We're more than happy to feature other of our community partners too.
Dr. Adler is volunteering.
No. I was telling him it got into my feed, so I was like, surprised.
I do have a question before we move on. Edie, last month we had a group of people here expressing concern about mental health care. And I asked you to connect with them. Have we had any?
I linked them up with our CCBHC project manager. I've seen some correspondence back and forth. I don't know how.
Okay.
Well, yeah.
Great. Well, thank you for doing that. Okay, all right. We're moving on to item 7, which is unfinished business. This is the letter to Governor Bob Ferguson from the Board of Health. Outlining the potential negative impact of loss of federal funds. I put together a letter and asked for feedback, and we have gotten some. I think the board has gotten copies of everything, the original letter with suggested changes. The first being that, starting on behalf of the board, that I'm submitting this letter, because as the chair, I'll identify that so they know who I am, and then the letter's actually coming from the entire board, that we have support of the board on that. So we have some language change there, and then Commissioner Lindy also submitted some few changes letter that you have in front of you today. I read through it. I think it's perfectly fine. Don't have any issues with changing it to include the added information that Commissioner Lindy put in.
Yeah, and I'll just say that the essence of my changes were really just kind of a little bit of a grammatical polishing a little bit was all. It didn't change the content of anything there. I think personally, I think it's a very good letter. I think I like the content and I like the tone.
Keeping in mind the content and the tone, there doesn't seem to be any specific ways in which to improve federal funding highlighted. Is there any idea as to how we could suggest the ways in which our federal funding might be highlighted that the governor could take immediately or in the near future?
That will be up to the governor in terms of what he is willing to do in cooperation with the federal government.
But we don't want to put it in our letters, like I think I'm suggesting. So on Don's idea of tone, it's a non-offensive letter, so therefore it's a good tone.
Thank you. I was trying to be very succinct in terms of what our concern is and offer the opportunity to take up on that.
I like the sentence. Thank you for bravely stepping into the leadership role. Now, a lot of bravery.
Yes, that was very diplomatic.
Yes, Delene?
I just, there doesn't seem to be any kind of acknowledgement of the federal government's role and what their role is supposed to be. I mean, this doesn't align with the Constitution. Trying to seek federal dollars for public health stuff, that's not a role that was given to them. And so
A role that was given to,
the federal government. I mean, that's way out of their lane. And so I guess I'm just wondering why we're seeking money and services from them that they're not supposed to be involved with.
well, there's funding, whether they're supposed to be or not, there's funding that comes from the federal government into the state for a multitude of things that likely that money will be or is being withheld because there's a disagreement between the state and the federal government in terms of policy.
So you're saying just because it's been done and they've gotten away with it, we should just continue supporting that and not try and go back to what the Constitution is supposed to be?
So what would you recommend?
Not accepting money from the federal government, I'm not seeking it. Because it always comes with strings and bureaucracy and it takes away our ability, kind of as we identified with other issues like with hospitals, the more you centralize control, regulation, and power, the less ability you have at a local level to be flexible and make decisions that apply, and it's kind of a one size fits all, no matter if we're on the east side of the state with certain climate and the west side of the state with a different climate, the things don't apply the same. And so it takes away our ability at a local level to make our decisions. So, yeah, I think we
That's
should.
one way of looking at it. Another way is, we are trying to get the funding that we need for the services with that. So we're making an effort locally to do that. by saying, you know, we can have the state look at different opportunities with the federal government to get funding into the state.
Or, and I would like to highlight, I mean, you specify critical services.
Yeah.
I mean, we're not going, asking for federal dollars for anything outside of a critical service.
Well, yeah, now we could get into definitions and whose definition of critical.
Critical is,
But
yeah.
again, like, I mean, that was the whole spirit of the Constitution and the framers and why they did it the way they did it was that it should be the rule of law, not our emotions or our, you know, what we think is good or bad. I mean, it keeps the government in its place when you follow it. And what's happened is we haven't been following it, so we've gotten way off track and not better outcomes. They could do better coming up with things at a local level. And I think as elected people, there's many elected people on this board, there was an oath taken, was there not, to uphold the Constitution? So everything should be done through the constitutional lens, first and foremost. So that's my just offering on the subject.
So your suggestion would be that we not send the letter.
That's my suggestion. We not seek federal dollars.
Well, I guess because the federal dollars are currently needed, I would suggest that we should at least acknowledge the fact that we would rather not lose them. Whether we agree that they should be there or not is a separate question, but I do think that because they are there and we are dependent upon them for some of the programs, then I would choose to send a letter acknowledging that we are at risk of losing these funds if we don't, I guess, fall in line with the prescribed principles of how they're releasing money. But I don't disagree with you on the concept of government's too large. I do think, though, that we're not going to change government being large in this body. So therefore, acknowledging that fact and then acknowledging that we would like the funds anyhow is an important step that we can make now and will be heard. I'm not sure we'll see anything of it, but we will at least be heard.
Well, I mean, I appreciate that. I do understand we've kind of gone down this road a long time and, you know, it's not likely it's gonna be the flip of a switch, but that kind of mindset is what got us here. And if we don't change that mindset at some point, we're gonna continue on the path of bigger government, never trying to rein it in. And no, overall, I don't think this body is gonna change the overall size of government, but it can affect some changes on a local level that actually can work, I think.
I always look at the principle of, is this the hill to die on? This is not for me the hill to die on. So I would argue to ask for a release of the money.
Go ahead. If you don't mind, I understood the board's interest in this letter was specifically aimed at communicating directly to the governor about the value of state funding being received here. And that the discussion of the federal funding was secondary to that because there is concern that there will be limited funding in that area. But the idea was to ensure that if there was available state funding, it would be secured and then be available for us. I think that was the intention.
I thought the intention, Andre, just to clarify, at least the way I heard it, was that policies that this governor is going to take with this state are going to put at risk federal funds that might be withheld from us. And therefore, the direct result of the letter was to address that the state's policies might get in the way of our federal funds being accepted. Or
That's fair.
being eligible.
That's fair. Well, and to bring to your point, we will follow the law. So, I mean, that's paramount for me is if it's legal, we'll do it. And if it's not legal, then that's in question, then that's something we won't entertain.
Well, it is illegal because the Constitution's the law of the land. So anything that violates that is illegal.
Well, if I could add something, and I appreciate, I actually appreciate the fact that the federal government is actually looking at the debt because our path we're on financially is frankly unsustainable. I mean, it has to be looked at. Now, whether we're talking about doing it with a hatchet or doing it with a scalpel, could be under debate. I think we've got to be kind of thoughtful on how the approach is. But if we want to lean back to the Constitution, this is your preamble. It says that we, the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, to ordain and establish this Constitution for the United States of America. And I'll say, when you look at that, it leaves a lot of discretion to us as people on what that means. So,
It doesn't, though, if you read Article 1, Section 8, those are for the enumerated powers to the federal government. It was only instituted for specific purposes. And that was
well,
outlined
we've
in
argued about this a long time.
Article 1.
But I'm just saying, whether we like it or not, the government we have right now is the government that's been passed by law, and it's, we can worry about efficiencies and sometimes even fraud in some cases, which is out there, but,
Well, as we listened to the discussion this morning, we're very aware of that.
yeah. Yeah,
And overall, we'd like to not lose any money
correct.
if we could help it.
So, Madam Mayor, I'll just go ahead and move that we authorize the chair to sign the letter that's been presented.
No second.
We have a motion and a second to authorize the letter that's been presented.
With the edits, I guess, just for the.
Yes, yes, thank you very much for the words with the edits. There were-
This one, right?
Was that your intent?
Yeah, I thought this was the final version because you liked.
Yeah. Thank you. All right, I don't think we need to take roll call. I think it's call for a vote. All those in favor, please say aye.
Aye.
And those opposed.
Nay.
Okay, thank you. So motion passes by majority. Thank you, and thank you, Daleen, for bringing that up. I think it's always really good discussion. I will say, in my presenting the letter initially, I wanted to be as succinct as possible. Asking the governor to consider. And I just would encourage individuals, if you have concern about the constitutional side of the issue, this is one example to give in reaching out to political entities or reaching out even as individuals to your legislator and the people that, that you have a desire to move back toward more constitutional law. Thank you. Okay. Any other comments? Then we'll move on. My last is I'm sorry. Next on the agenda is new business. So we have proposed a motion to approve the local on-site wastewater disposal ordinance. So Mr. Reed is going to talk to us about this.
Yes, as I previously mentioned in my report, the new Washington Administrative Code 246-272A has been revised by the state of Washington. That most of that new WAC goes into effect April 1st this year. So,
Another April 1st.
yeah. And the more hands-on portion of that WAC goes into effect April 1st, 2027. So we have time to implement the things we need to do to meet that deadline. However, the pieces of this WAC that are going into effect here in a few days is the new minimum lot sizing requirements for septic system permitting. It has a more specific breakdown of treatment levels based on soil depth and soil type. For example, if you have a silt loam versus a clay loam, you need more enhanced treatment to get wastewater to infiltrate through a clay loam and effectively be made safe for reentry into the aquifer. And so those things are going into effect here in a few days. What we've done in the past when there's WAC revisions and updates, we have adopted those. And our practice is that through our permitting process, we ensure, in this case, septic permits, so septic systems are designed and installed to meet the minimum requirements of the WAC. We have the ability to be more strict, but we use the administrative codes as our guide and what the minimum standards are for getting those systems permitted and being installed into the ground and bringing online to be used. So that is the purpose of this ordinance, to recognize that this WAC has been updated and we need to adopt it as, you know, our code for regulating septic systems in Yakima County.
Any questions?
Is this a major overhaul, like our home builders locally? I mean, does this impact them drastically or?
It has potential to. So for example, if we have a development being done that's gonna utilize on-site sewage systems and they're 1/4 acre lots. They show they have the space for individual septic systems with replacement area. The minimum, they're under the minimum lot sizing requirement for just a normal gravity conventional septic system. If there's certain soil types, if the soil type is not favorable to have a septic system, we start talking about nitrogen loading calculations. And nitrate's a problem all over the state, so that they built it into this new WAC to be able to for source control of nitrates being introduced into it. So in some instances, nitrogen loading calculations have to be done, and if they exceed that loading requirement, then different treatment media can be added to the septic system to reduce that below the loading threshold. But it also gives us on larger lot sizes or areas where soil is very deep without restrictive layers, the ability to utilize a wider array of treatment levels and make systems much simpler, much more affordable, much easier to permit.
Thank
So it goes both directions.
Sean, and part of the process for revising codes is public comment, and so home builders associations, you know, had the opportunity to
Yes.
have input.
Yeah, this WAC revision took all of 6 years. So it has been many iterations of it, and this is what they landed on. In 2027, the other requirements that are implemented are property transfer inspections. So if you go to sell a home, it's required that the septic system is inspected by a licensed professional. And if there's any major issues identified, it could be a requirement that those were repaired prior to the transaction of that property. In addition to that, an operation and maintenance schedule is a requirement of the new WAC, where depending on the type of system you have, you should have it looked at by a licensed professional every, you know, could be annually, it could be every 3 to 5 years, depending on the system. However, in the WAC, there's no enforcement mechanism of those things. So, you know, we have a couple of years to develop what that policy could look like and how that could work.
So if somebody has a home under the previous WAC, and then 5 years down the road, they sell the home and there's an inspection that has to take place.
Mhm.
If there was a change that had to be made in the WAC, they would have to change their system.
No, the system is still a conforming and permitted system, even if it wouldn't necessarily be that way if it was a new install under the current WAC. They don't have to update the system to meet current code. It's more, is the tank cracked? Is there a broken line? Is there backflow from the drain field to the tank? You know, it's just is the system still working the way it should?
So
And if I-
changes in the WAC would be just for new construction. to-
New construction or permittable repairs. So if the drain field was failing.
Okay, thank you.
If I may, this is more structured governance and oversight. Many homes have to meet those inspection requirements because lenders require you to get them inspected. So it's been a privatized process for many years here that people have to get those things done because nobody wants to buy a property only to find out that they have a defective system that's going to cost them a lot of money. So the industry has corrected, but also we're looking for the least invasive and technically complicated way to meet state law, and that is to adopt this because we could be more restrictive, but not less. So.
Yes.
I appreciate that.
So that, yes, that is the purpose of the ordinance. Recognize this is the new regulation. And we'll follow that regulation, but not be more restrictive.
Thank you. Any other questions?
I would just comment that I appreciate the fact that you're doing just what's necessary and no more.
If there's no more questions, I would entertain a motion.
I move to approve the local on-site wastewater disposal ordinance.
I will second.
Thank you. So we have a motion and a second to approve the new local on-site wastewater disposal ordinance. All those in favor, please say aye. Aye. Okay, I'm gonna retract that. I'm so sorry, because it is an ordinance, we need a roll call vote.
Okay. Okay, if you're in favor of the motion, please state yes. If not, please state no. Commissioner Lindy,
Yes.
Edie Dibble, Aileen Ackerman,
Yes.
Peter Carrillo,
Yes.
Dr. Atterbury,
Yes.
Commissioner Curtis,
Yes.
and Mayor Byers.
Yes. So that is, the motion is approved, ordinance is passed by 7-0 vote.
Did you ask Catherine Saluska?
Oh, Catherine.
Oh, yep, Catherine and Catherine.
Yes.
Okay. It was on a different-
Vote by one, but it's unanimous. Thank you very much. All right, if there is no other business. Any new business on the board? Then I would entertain a motion to adjourn.
Second.
Do we have a motion and a second to adjourn to our next regular scheduled meeting on April the 30th, 2025? No, we're not able to do this. April 30th, 2025. All those in favor, please say aye.
Aye.
Any opposed? Thank you very much.
Thank you so much.